Welcome to the deep dive. Today we're tackling a subject that sounds almost like science fiction, but is actually very real. Gas embolism. We're talking about what happens when gas, bubbles get trapped inside your blood vessels.
Right.
Now, you might think of those tiny bubbles you sometimes see in an IV drip. Usually harmless, right?
Generally, yes, in small amounts.
But when larger amounts of gas get into the bloodstream, well, things can get dangerous, even fatal.
That's exactly right. And to really get a handle on this, we need to talk about the two main types. There's venous gas embolism, VGE for short, and arterial gas embolism, or AGE.
Okay, VGE and AG, what's the key difference?
Well, it's mainly about where the gas goes first and how the body tries, to deal with it. With VGE, the bubbles are in the veins. They typically travel towards the lungs.
The lungs, like a filter.
Precisely. The lungs act like a filter. They can often trap and dissolve small amounts of gas. But if there's a massive amount of gas, or if the lungs aren't working perfectly, that filtering system gets overwhelmed. And then those venous bubbles can actually cross over into the arterial side. That leads to AG.
So VGE can become AGE.
Yes. And what's also fascinating, sometimes VGE can bypass the lungs completely.
Yeah.
Through these abnormal connections, shunts in the heart, or even the lungs themselves.
Shunts, like shortcuts.
Exactly, like secret shortcuts, letting the gas go straight into the arteries.
Okay, let's unpack that a bit. So, VGE, the lungs usually catch it. That's the first line of defense.
Right.
But a big surge of gas, or these shunts, these hidden paths, means the gas bypasses that safety net. And that's when it causes serious problems in the arteries.
You've got it.
Okay. So our source for this deep dive is a chapter from the textbook Hyperbaric Medicine Practice. Looks like a really thorough look at gas embolism.
It is, yeah. Very comprehensive.
So our mission today is to get a really clear picture of how this gas ends up in our blood in the first place, what harm it can do, how our bodies react, and crucially, what treatments are out there.
Sounds good.
So where does this gas even come from? How does it get in?
Well, the chapter lays out several key ways. The first big one is something called excessive alveolar stretch.
Alveoli. Those are the tiny air sacs in the lungs, right, where oxygen gets exchanged.
Exactly. The tiny air sacs.
So excessive stretch sounds like you're overinflating them until they pop, like blowing up a paper bag too much.
That's actually a really good analogy. A classic example is breath holding during an ascent from a scuba dive.
Ah, diving. Makes sense.
Yeah. As a diver comes up, the pressure around them drops, right? So the gas they breathe underwater, which is trapped in their lungs, expands if they hold their breath. Well, yeah. That expanding gas can overstretch and rupture those delicate alveoli and the tiny blood vessels right next to them. And boom, gas bubbles straight into the bloodstream. AGE.
Okay, but here's where it gets, really interesting for me. The chapter says this can happen even if you don't hold your breath.
That's true. Certain lung conditions can predispose you.
Like
things like they're like air-filled blisters in the lung tissue, or cysts, or even diffuse airway obstruction, like in asthma. These can weaken parts of the lung.
So the lung tissue is already compromised.
Right, making it more prone to rupture even with normal pressure changes during ascent. And get this, they even talk about paradoxical AGE in breath hold divers.
Paradoxical? How so?
The intense compression on the lungs during a deep descent can actually injure those tiny alveolar capillary membranes. Then, when the diver ascends and the lungs re-expand, gas can enter through that injury site.
Wow, that's completely counterintuitive. Injury on the way down causes gas entry on the way up.
It is. It highlights the complex pressure dynamics involved. And it's not just diving.
No.
Hyperexpansion of those bullae or cysts. It can happen just with changes in altitude. Even, believe it or not, flying in a commercial airplane.
Seriously, on a regular flight.
It's rare. Definitely rare. But there are documented cases of AGE happening mid-flight because of this underlying lung vulnerability.
Huh. You just wouldn't expect that. What else can cause this alveolar stretch?
Well, some breath hold divers intentionally overinflate their lungs before diving. It's a technique called glossopharyngeal insufflation, basically gulping extra air. That increases risk.
Right, packing more air in.
Then there's penetrating chest trauma. A wound, basically. Even without a big pressure change, it can let air into the chest cavity and potentially the bloodstream.
Okay.
Acute inflammatory lung diseases, like severe pneumonia, can weaken the lung tissue too, even without someone being on a ventilator.
So the infection itself makes the lung fragile.
Correct. And Ironically, positive pressure ventilation itself, being on a ventilator while life-saving, can sometimes force air into the circulation if the lung tissue is particularly fragile or damaged. And finally, blast injuries. They can cause severe lung damage from the pressure wave that's pulmonary barotrauma, a major cause of gas embolism in those situations.
Okay, so the lungs are clearly vulnerable to pressure changes, both up and down, and direct injury. That's one major pathway. But the outline also mentioned iatrogenic causes. That means caused by medical treatment, right?
Yes, iatrogenic means resulting from medical intervention.
It's a bit unsettling, isn't it? Thinking that medical procedures could actually cause this.
It is, unfortunately. While obviously intended to help, procedures can sometimes inadvertently introduce gas. A classic, though thankfully pretty rare example, is accidentally injecting air intravenously.
Right, like an empty syringe.
Exactly. But there are many other scenarios. Complications during heart-lung bypass surgery, needle biopsies of the lung, hemodialysis.
Hemodialysis, wow.
Yeah, and even placing or disconnecting central venous catheters, central lines.
Central lines, you hear about those all the time in hospitals. How does that cause an embolism? Seems common.
Well, think about where those lines often sit in large veins near the heart. If a connection isn't secure or it gets disconnected and the pressure inside that vein is lower than the air pressure outside.
Like if the patient's sitting up.
Precisely. If the entry point is above the heart, the venous pressure there can be subatmospheric. Air can literally get sucked into the line, like a straw with a leak.
Okay, that makes sense. That's definitely unsettling. What other medical causes are there?
Let's see. Gastrointestinal endoscopy, using hydrogen peroxide to irrigate wounds.
Hydrogen peroxide? How?
It reacts with enzymes in the tissue and releases oxygen bubbles. If it gets absorbed systemically, those bubbles can cause embolism.
Huh, okay.
Then there's arthroscopy, knee surgery, shoulder surgery, even CPR in rare cases. Liver procedures like percutaneous hepatic puncture. A rare complication of treating atrial fibrillation called an atrioesophageal fistula.
That sounds serious, a connection between the heart and the esophagus.
It is very serious, yes. And then you have procedures where the surgical site itself is pressurized. Things like laparoscopic surgery, transurethral surgery for the prostate, some eye surgeries like vitrectomy, endoscopic vein harvesting for bypass surgery, hysteroscopy.
It really sounds like almost any procedure that involves opening the body or using pressurized fluids carries some potential risk, however small.
That's a fair summary. And the outline also mentioned massive VGE from passive air entry in elevated surgical wounds. This is a big one.
Right, tell me more about that.
This is a significant concern in surgeries, where the surgical site is physically higher than the patient's heart. Think about brain surgery, where the patient might be in a sitting position, a sitting craniotomy.
Okay.
The pressure in the veins at that high point in the head can easily become negative relative to the atmosphere. So air just gets sucked into any open vein, and it can be a lot of air.
Wow.
This can also happen in C-sections, certain types of prostate surgery, spine surgery, hip replacements, liver surgery, even dental implant procedures.
Dental implants.
Yes. Some veins, particularly the ones inside bone intraosseous venous lakes, they're called don't collapse easily, like veins in soft tissue. So they can stay open and just suck air in if the pressure gradient is right. That's quite a list of ways gas can get in medically.
Yeah.
Okay, let's shift gears again. The outline mentions decompression-induced bubble formation. This takes us back to diving, doesn't it?
Absolutely. This is a core concept in diving medicine. VGE, venous gas embolism, is actually pretty common after dives using compressed gas.
Common, but usually not serious.
Exactly. Most of the time, these are tiny bubbles, what we sometimes call silent bubbles. The lungs filter them out, as we discussed, and the diver feels nothing. No symptoms.
Okay.
But if the dive was particularly deep or long, or the ascent was too fast, a larger volume of VGE can form. Now the lungs might get overwhelmed.
And then you get symptoms.
Right. Symptoms like coughing, shortness of breath, maybe even fluid buildup in the lungs, pulmonary edema. That's sometimes called the chokes in diving slang. And crucially, if the volume is large enough, it can overwhelm the lung's filtering capacity or bypass it.
Leading to AG.
Leading to age, or don't forget those shunts we talked about.
Right, the shortcuts, like a hole in the heart. Yes, things like an ASD atrial septal defect or a PFO patent foramen oval. That's a small flap between the heart's upper chambers that doesn't fully close in some people, or even shunts within the lung tissue itself.
So if a diver has one of those?
Then even a moderate amount of VGE, bubbles that might otherwise be filtered, can just zip right through the shunt, bypass the lungs, and go straight into the arterial circulation. instant AGE potential.
It's like a trapdoor for the bubbles.
Pretty much. And high volumes of EGE can also increase the pressure in the pulmonary artery and the right side of the heart. Interestingly, that increased pressure can actually force open a PFO that might normally stay functionally closed.
Making the shunt problem worse.
Exactly, facilitating that right-to-left shunting of bubbles. And it's not just diving.
What else causes decompression bubbles?
Rapid exposure to low ambient pressure. Think fighter pilots making a rapid ascent, people in altitude chambers, or an accidental rapid decompression of an aircraft cabin at high altitude.
Like in the movies?
Sort of, yeah, though usually less dramatic. But a rapid pressure drop can cause dissolved nitrogen in the tissues to come out of solution as bubbles, primarily VGE. The threshold for this, without breathing pure oxygen beforehand, is around 15,000 to 17,000 feet.
Okay, so high altitude exposure too. Interesting. The last category was just other causes. What's in there?
A couple of less common but important ones. We mentioned hydrogen peroxide irrigation, but actually ingesting concentrated hydrogen peroxide can also cause problems.
Drinking it.
Yes. An enzyme in the body, catalase, breaks it down rapidly into water and oxygen gas. That oxygen can form bubbles and get absorbed systemically.
Wow.
Okay, and perhaps surprisingly, there are documented cases of massive VGE after someone blows air into the vagina, usually during orogenital sex.
Really?
Yes. The vaginal tissues have a rich blood supply, and under certain circumstances, the air can enter the veins there, particularly during pregnancy when the veins are more dilated. It's rare, but it happens and can be fatal.
Okay, that's definitely one you don't hear about often. It really drives home how unexpected the routes can be for gas to get into the circulation.
It certainly does.
So we know how the gas gets in. Now, what kind of damage does it actually do? What are the mechanisms of injury?
If you have a large volume of AGE, the most straightforward mechanism is just physical blockage. The bubble literally plugs up a blood vessel.
Like a clot, but made of gas.
Exactly. This cuts off blood flow, cuts off oxygen downstream. That leads to tissue infarction, tissue death, brain, heart, wherever the bubble lodges.
Okay, that's the big bubbles. What about smaller ones?
Even small bubbles cause trouble. They don't necessarily block the vessel completely, but they damage the inner lining, the endothelium.
And the endothelium. You said it's like the smooth lining.
Right. It's supposed to be smooth and allow easy blood flow. Bubble contact injures it, makes it sticky, inflamed.
So it's not just a plug, it's damaging the pipe itself.
Precisely. And this endothelial damage has knock-on effects. It makes white blood cells, leukocytes, stick to the vessel wall.
Ah, inflammation.
Yes. These sticky leukocytes can then clump together with platelets and the bubbles, further clogging up smaller vessels, the microcirculation.
Okay.
Plus, that damaged endothelium becomes leaky. Plasma, the fluid part of blood, starts leaking out of the vessel into the surrounding tissue.
Causing swelling, edema.
Exactly, edema. In the lungs, this contributes to pulmonary edema. In the brain, it causes cerebral edema, swelling of the brain tissue. That's really dangerous because the skull is a fixed box. Swelling increases pressure inside the skull.
Which crushes the brain tissue and reduces blood flow even more.
Correct, leading to brain hypoxia, lack of oxygen.
And this plasma leak, does it affect the blood itself?
Yes. Losing plasma fluid makes the remaining blood thicker, more concentrated. That's hemoconcentration.
So thicker blood is harder to pump.
Right. And if the leak is severe enough, you can lose a significant amount of total blood volume. That's hypovolemia. Both make it harder to deliver oxygen where it's needed, and there's more.
More? Oh, boy.
That damaged endothelium. It also messes up the normal regulation of blood vessel tone. Vessels might dilate inappropriately, that's called vasoplegia, and they might not respond properly to medications we use to raise blood pressure.
So it becomes hard to even treat the low blood pressure caused by the embolism?
It can be, yes. It's really a cascade of harmful effects, starting with the bubble, but triggering all these secondary injury mechanisms.
Okay, that's a grim picture of the damage. How does this manifest? What does it actually look like when someone has a gas embolism? What's the clinical presentation?
With AG, arterial gas embolism, the bubbles often go to the brain because it receives a lot of blood flow. So the symptoms are typically neurological. Often it looks very much like a stroke.
Like a stroke. So what specifically?
Things like sudden loss of consciousness, confusion, seizures, weakness or paralysis on one side of the body, hemiparesis, abnormal body posturing in severe cases, even cardiac rhythm problems, arrhythmias. It can be very dramatic.
Sounds like it. But the chapter notes mention mild AG can have subtle signs. What should people look out for there?
Subtle things, yeah. Maybe just slight confusion, dizziness, visual disturbances, numbness. Things that might only be picked up with a really careful neurological exam. It's not always the full-blown stroke picture.
Right.
And interestingly, in divers who already have a lot of nitrogen dissolved in their tissues from the dive.
From decompression sickness risk.
Exactly. In those cases, AGE might present more like decompression sickness affecting the spinal cord, maybe causing paraplegia, weakness in the legs rather than the typical brain symptoms. It seems the arterial bubbles might preferentially cause problems in tissues already primed for bubble trouble.
Huh. So the context of the dive matters.
It does. And while the brain is the most common target for AGE, remember, bubbles can go anywhere the arteries go. Heart, kidneys, gut. Other organs can be affected too.
Okay. What about those really specific signs mentioned? Boxcars in the eyes, Liebermeister's sign.
Yeah, those are interesting. Retinal gas embolism. You need an ophthalmoscope to see it can make the blood in the tiny retinal arteries look segmented, like a train of boxcars. It's not always present, but if you see it, it's a strong sign.
Okay.
Liebermeister's sign is even rarer. It's this weird modeling pattern on the tongue, sharply defined pale areas. Very specific for AGE, apparently, but almost never seen.
Wow, okay, those sound like specialist signs.
Yeah.
What about VGE, the venous side? How does that present?
Well, as we said, small amounts of VGE might cause no symptoms at all, silent bubbles.
Filtered by the lungs.
Right. But if you get a significant load of venous gas, it can overwhelm the pulmonary circulation. That can cause low blood pressure, hypotension, rapid breathing, tachypnea, low CO2 levels, hypocapnia, that pulmonary edema or jokes we mentioned, and in really severe, massive cases, cardiac arrest.
And AGE symptoms can happen alongside VGE symptoms, right? If the bubbles cross over.
Absolutely. If VGE gets arterialized, either by overwhelming the lungs or via those shunts, then you can have the whole range of neurological AGE symptoms on top of the respiratory or cardiovascular VGE symptoms.
Man, diagnosis sounds tricky. Symptoms overlap with strokes, heart attacks, lung problems. How do you confirm it? What about diagnostic tests?
That's a key point. While imaging like CT or MRI might show air in blood vessels or evidence of stroke, the chapter really stresses that these scans are often normal, even when someone has severe neurological problems from AG.
Normal, even with bubbles causing havoc.
Yeah, the bubbles might be too small, too transient, or have already caused damage and moved on by the time the scan is done. So you absolutely should not rely on imaging to make the diagnosis or delay treatment waiting for a scan. Time is critical.
Okay, so don't wait for the scan if you suspect it clinically. Got it. Are there other clues, though, things that support the diagnosis?
Yes. Finding evidence of pulmonary barotrauma, lung injury from pressure can be a big clue, especially in diving or ventilator cases.
What kind of evidence?
Things like air leaking into the space around the lungs and heart that's mediastinal emphysema. Sometimes that air tracks up into the neck, causing subcutaneous emphysema, that crackly feeling under the skin.
Like bubble wrap under the skin.
Kinda, yeah. Or air can get around the vocal cords, causing a hoarse voice. Rarely you might hear a crunching sound over the heart with each beat Hammond sign. Seeing those things strongly suggests air has escaped the lungs, making AGE more likely.
Okay. Any other confirmatory signs?
Well, sometimes you can actually see the gas. Using ultrasound over the heart or major vessels might show bubbles. Or if the patient has a central line, you might be able to aspirate frothy blood or gas directly from it. That's pretty definitive.
Right. Direct evidence. What about blood tests? Anything useful there?
Not really for immediate diagnosis. Standard lab tests are usually nonspecific. The hematocrit might be high because of that plasma leak, showing hemoconcentration. CPK, a muscle enzyme, might rise later, but it's not helpful up front.
So bottom line on diagnosis, it's mostly clinical.
Pretty much. It's about putting the picture together.
Yeah.
The sudden onset of symptoms, especially neurological ones, happening in a situation where there's a clear risk for gas getting into the circulation, diving, surgery, trauma, central line issue, etc.
Right. The context is key.
Exactly. And the strong advice is, don't delay treatment for extensive, often unhelpful imaging. Treat based on clinical suspicion.
Okay, that makes perfect sense. So let's talk treatment. What are the first steps? Supportive first aid treatment. What do you do right away?
The absolute immediate priorities are the ABCs, basically. Maintain their airway, ensure they're breathing and getting enough oxygen, treat hypoxia, and support their circulation, maintain blood pressure.
Okay. Standard emergency care.
Yes, but with some specifics. You want to maintain normal carbon dioxide levels, isocapnia. Hyperventilating them, trying to blow off CO2 to lower brain pressure, hasn't been shown to help in AGE according to animal studies and might even be harmful.
Interesting. What about fluids?
Feed fluids are usually needed to combat that hypovolemia from the plasma leak. but crucially, avoid fluids containing glucose.
Why no glucose?
Hyperglycemia, high blood sugar, is known to worsen outcomes after brain injury, including stroke and likely AGE. So, stick to saline or similar fluids. Also, while you hydrate aggressively for decompression sickness, you might be more cautious with fluids in isolated AGE to avoid worsening brain or lung swelling. That's a bit of a balance.
Okay. And oxygen. We always hear about oxygen for diving accidents.
Absolutely critical. Give the highest possible concentration of inspired oxygen immediately, 100% if possible.
Why is oxygen so important here?
Two main reasons. First, it helps oxygenate tissues downstream from any blockages, the ischemic tissues. Second, and very importantly for gas embolism, breathing high oxygen increases the pressure gradient for inert gases, mainly nitrogen, to diffuse out of the bubbles and back into the blood, shrinking the bubbles.
It helps dissolve the bubbles faster.
Exactly. It creates a bigger push for the nitrogen to leave the bubble. First aid oxygen is a Class 1 recommendation for suspected decompression illness in diversa sovers, meaning strong evidence supports it.
Okay. What about positioning the patient? I feel like I've heard conflicting things. Head down. On their side.
Yeah, there's been historical debate. The old idea was Trendelenburg head down to try and trap air bubbles in the bottom of the heart using buoyancy.
Right.
But studies showed buoyancy has little effect on bubble distribution, especially in the arteries. And worse, the head-down position definitely increases intracranial pressure and can worsen cerebral edema. So that's out.
Okay, no head down. What's recommended now?
Supine. Flat on their back. That's the current recommendation.
Supple enough? What about lying on the left side? Left lateral decubitus. I thought that was for VGE.
That was also suggested, the theory being it might trap venous air in the right ventricle and stop it going to the lungs. But again, there's little hard evidence that makes a big difference, and fiddling with positioning can delay other crucial treatments like oxygen or transport. So generally, supine is preferred.
Okay, supine it is. So that's first aid. What's the definitive treatment? Hyperbaric treatment comes up next.
U-chamber. Yes. Hyperbaric oxygen therapy, HbO2, is considered the definitive treatment for any gas embolism causing significant symptoms, neurological, heart, lung problems, or other organ issues.
But not for just, like, silent VGE bubbles.
Correct. If someone has, say, bubbles seen on an echo after a dive but feels totally fine, HbO2 isn't usually indicated. The body can handle that. But for symptomatic AG or severe VGE, it's the main therapy.
And you decide based on symptoms, not just scans.
Absolutely.
Oh.
The clinical picture drives the decision. Reviews consistently show much better outcomes, less disability, higher survival for patients treated with HbO2 compared to those who only get supportive care without recompression.
Makes sense. Is there a time limit? We often hear time is brain with stroke. Is it the same here? Do you have to get them in the chamber within like an hour?
Well, faster is definitely better. Shorter time from the embolism event to starting HbO2 treatment is generally linked to better outcomes, no question. But it's not like there's an absolute cutoff, a magic window, after which it's pointless. Gas bubbles can actually persist in the body for quite a while. There are many cases where patients treated hours, even a day or two later, still had significant benefit from HbO2.
So it's always worth considering, even if there's a delay.
Definitely worth considering. And another point, sometimes patients might seem to improve initially with just first aid oxygen.
Right.
But there's a known risk of secondary deterioration hours later. So even if symptoms start resolving, HbO2 is often still recommended to prevent that potential worsening and ensure the best possible outcome.
Okay, so what does the hyperbaric treatment actually involve? What happens in the chamber?
The standard initial approach, especially for diving-related AGE, is usually based on the U.S. Navy treatment Table 6 or something equivalent.
Table 6, what does that mean practically?
It means compressing the patient in the chamber, breathing 100% oxygen, to a pressure equivalent to 60 feet of seawater, that's 2.8 atmospheres absolute, or ATA. The treatment involves specific periods of breathing oxygen alternating with air hugs over several hours.
Okay. Do they ever go deeper?
Deeper initial compression used to be done sometimes, but 2.8 ATA is now the standard starting point. Going deeper might be considered if the initial response isn't great, but it carries more risks and needs special facilities. There are also shorter treatment tables, especially for monoplace, single-person chambers, that seem effective too.
And it might take more than one treatment.
Oh, yes. Often patients receive repeat HbO2 treatments, maybe once or twice a day, until they stop showing clear stepwise improvement. This could be just 1 or 2 treatments, or sometimes 5, 10, or even more in severe cases.
Right. Now, what if the person has a collapsed lung, a pneumothorax, from the same bare trauma event that caused the embolism? Is it safe to put them in a pressure chamber?
That's a critical safety point. A pneumothorax can get worse under pressure changes. So if a pneumothorax is present or strongly suspected, especially from barotrauma, the recommendation is usually to place a chest tube before starting HbO2.
To drain the air.
Exactly. Especially in a monoplace chamber where you can't intervene during the treatment. In multiplace chamber where staff are inside with the patient, very close monitoring might be an alternative in some situations, but a chest tube is generally safer.
What about just air in the chest cavity, the pneumomediastinum?
That usually isn't a contraindication. The air typically gets reabsorbed during the HbO2 treatment itself.
Okay, so hyperbaric oxygen is the core. Are there other things, adjunctive therapies, that help?
Yes, the Undersea and Hyperbaric Medical Society, UHMS, has reviewed evidence for several add-on treatments. One with some decent support is lidocaine.
Lidocaine, like the local anesthetic.
Yes, but given intravenously, it has anti-inflammatory and possibly neuroprotective effects. Animal models of AGE show benefit, and some human trials in bypass surgery suggested it might help reduce neurological issues.
So is it recommended?
It's considered Class 2A Level B evidence, which means it's reasonable to consider it. The benefit might outweigh risk, but the evidence isn't absolutely definitive for AGE specifically. If used, you aim for standard antiarrhythmic blood levels.
Okay. What about common stuff like aspirin? Or steroids like dexamethasone?
Aspirin. Well, there's no solid data showing it helps specifically in AG. It gets a weaker recommendation. Class 2B, Level C, basically. Use is uncertain. Interestingly, another anti-inflammatory, tanoxicam, showed some promise in reducing the number of HbO2 treatments needed for decompression illness overall, but not specifically AG.
And steroids. Dexamethasone is often used for brain swelling.
Right, but animal studies of AGE haven't shown a benefit from corticosteroids, and they have downsides risk of high blood sugar, infection. So they're generally not recommended for AGE. Class 3 recommendation shouldn't be used routinely.
Okay, so lidocaine maybe, aspirin uncertain, steroids probably not. What else?
Two important supportive things. First, DVT prophylaxis, preventing blood clots.
Because they're immobilized.
Exactly. If someone has significant neurological injury and is stuck in bed for more than a day, they're at high risk for deep vein thrombosis in their legs, which could lead to a pulmonary embolism. So low molecular weight heparin is recommended Class 1, Level A evidence, strong support.
Makes sense. What's the second thing?
Temperature and sugar control. Avoid hyperthermia fever. Even mild fever worsens neurological outcomes after brain injury. So treat fever aggressively, keep them normothermic.
Right, keep the brain cool.
And avoid hyperglycemia. We mentioned avoiding glucose IV fluids. Monitor blood sugar and treat high levels, as that also worsens brain injury.
Okay, meticulous supportive care alongside the HbO2.
That's the essence of it.
Right. This has been incredibly detailed, a really comprehensive look at a complex topic. Let's try and wrap up with the key points in our outro.
Okay, I think the main thing is understanding that gas can get into our bloodstream in, well, a surprising number of ways. It's not just diving, it's medical procedures, trauma, altitude, even some really unexpected things.
Yeah, the range of causes was eye-opening.
And the effects. They can range from nothing at all to subtle neurological issues, right up to devastating stroke-like events or cardiovascular collapse.
So the big takeaways for everyone listening?
I'd say rapid recognition is key. Thinking about gas embolism in the right clinical context, knowing the risk factors, and then prompt treatment with supportive care and, crucially, hyperbaric oxygen for any significant symptoms. That's the most effective tool we have.
Absolutely. It's quite remarkable realizing the potential for this, like you said, in so many different settings. Some really unexpected, like the paradoxical breath hold diving issue or certain surgeries or even the sexual activity link. It really highlights why awareness is so important.
Definitely. For doctors, nurses, divers, pilots, even the general public to some extent.
Yeah.
Knowing the risks exists.
Knowledge is power, right? Even for something that seems as obscure as gas bubbles in your blood.
Indeed. And maybe a final thought to leave you with. As medical technology keeps advancing and more people participate in activities like scuba diving or high-altitude sports, how might all this affect how often we see gas embolism and how we manage it in the future?
That's interesting. Will new procedures bring new risks? Will better awareness improve outcomes?
Exactly. And what about ethical questions around awareness and prevention, especially in non-medical settings? Lots to think about. It's an area where ongoing research and just, staying vigilant will continue to be really vital.